I'm excited to be here at the European Hematology Association, or EHA, for presentation of a very rare tumor called blastic plasmacytoid dendritic cell neoplasm, or shortly known as BPDCN. And I'll be presenting results from our ongoing phase 2 trial with a novel agent called SL401.
Okay, could you give us a little bit of background about the disease?
Sure. BPDCN, or blastic plasmacytoid dendritic cell neoplasm, is an exceedingly rare hematologic malignancy. In fact, the name has changed many times over the past 3 decades, which adds to the diagnostic confusion. The good thing is that in 2008, patients with this disease have since now had a reclassification, and the World Health Organization, or WHO, published a very nice reclassification or categorization and placed BPDCN under the family of AML, or acute myeloid leukemia, and related family of neoplasms. So since 2008, the combination of having a category as well as having a very clear diagnostic triad of CD4 positive, 56 positive, and 123 positive, with the addition of other markers, has given rise to a uniform diagnosis for this historically very rare disease. Furthermore, if I may add, the disease has qualities of both leukemias, lymphomas, but also skin disorders as well. And because of that, it presents in the clinic with very difficult and confusing ways. And lastly, because it has these protean manifestations, the diagnosis and therefore the treatment have been very difficult, and there remains no standard of therapy for patients with BPDCN.
Which is where SL401 comes in.
Exactly right. So the results that we'll be presenting here are a very novel agent. It's SL401, which essentially consists of a truncated diphtheria toxin, which is then fused to human IL-3. And the reason why that's important is almost 100% of patients with BPDCN express or overexpress the IL-3 receptor alpha, known as CD123. And so we have a rare disease with a possible target, and we have a novel drug that hits said target. And so the hypothesis was that if we expose patients on the clinical trial to this novel agent, that we would hopefully have a high response rate and clinical benefit for these patients.
So what sort of dosages are you looking at?
So the doses is a very important question. It's a phase 1 study in the first portion, and it was a dose escalation. And as we've presented before in other conferences, and as we'll show here, we started out at the low doses, which was 7 micrograms per kilogram per day, and the drug is given over 5 days. It escalated up to 9 micrograms, and then ultimately culminated at the 12 microgram per kilogram per day dosing, again over 5 days. That dose, although there was not a formal maximum tolerated dose in the BPDCN cohort, it did result in early enough favorable activity where we were able to establish that as the dose, and now that's the dose that's moving forward in the phase 2 portion.
Okay, and when it came to the responses to these doses, what kind of results were you getting?
Right, so we've shown these results at ASCO last week, and we'll be updating them here at EHA this week. We report actually so far an 89% overall response rate in all lines and all doses treated in the BPDCN cohort. So those are very encouraging, exciting results thus far. Out of those 89%, the majority of them are actually either complete remissions, CRs, or a designated term called CRC, complete or clinical complete remission.
Okay, and when it comes to the administration of this, has it been as a single agent or in combination with anything else?
The administration of the drug in this clinical trial and thus far has only been with a single agent activity. Before this trial, there was only one prior clinical experience, an experience that I was a part of, published by my colleague, Dr. Art Frankel. And in that experience, a single agent, the same drug, SL401, was given actually just as a single dose. And in that study, 7 out of 9 evaluable patients actually had major responses, including 5 complete remissions. So this study is the first ever multi-center study, prospective, dedicated to patients with BPDCN. Same drug, SL401, but given now over multiple repeated cycles. But your question is very good and very important, which is as a single agent, we're seeing these encouraging results.
Well, these are significant results for a small phase 1 trial. What would the next step be?
The next steps for patients with this rare disease, BPDCN, is for us to continue the enrollment on this phase 2 portion now that we have identified a dose, and this is ongoing. So the study is continuing to enroll at the multiple sites. It's open in approximately 7 sites right now in the United States and Canada. And we hope to enroll more sites in both the States and Canada. So that's the first item for patients with this rare disease, is to continue enrollment. The second item for us to do is to then try to see if we can build on these data and use the results from this encouraging clinical trial to go for what's called a registration study for patients with this rare disease.
Okay, and you mentioned this was bound to a truncated diphtheria toxin, and repurposing other infectious agents, such as with the VTech repurposing of viruses and all kinds of other re-engineering of pathogens, has been generating a lot of interest. So any thoughts on that?
What a very good question. So in general, this field of immunotoxins is really expanding, as you said nicely. I think that this is a very important and new development for the field of oncology. You mentioned a few. I would also add to that list Pseudomonas-based toxins, which have been used, and other diphtheria toxin agents used before, such as the drug known as ONTAC, or Denlucan Diffitox, which is used in cutaneous T-cell lymphoma. So in principle, this is a very exciting field for oncology. And I think as far as the science and for our patients is concerned, we need to be keeping aware and studying the rare side effects that are sometimes only seen uniquely to this class of drugs. For example, there's a side effect known as capillary leak syndrome, which can be common in these bacteria or microbiological based approaches. And we did see some occurrence of this capillary leak syndrome in our current trial, and we've reported on this before. So I think that the understanding that this is a completely new and exciting field of oncology, coupled with the cautious optimism and also vigilance and rigorous monitoring for these unique side effects that these agents may have, really opens the door for a new way to treat cancer patients.
Well, that's all the questions I've got prepared. Is there anything you'd like to add?
I think basically the last thing I would add is that patients with rare cancers and rare diseases oftentimes have really a paucity of information out there. And I think that it's important for patients to know that there are doctors, clinicians, researchers such as myself and my co-investigators who have dedicated their life and their careers to really finding out solutions and cures to these rare diseases. So I want to let folks know out there that there is a big movement in the cancer field to break down cancers into very specific, unique subtypes, such as BPDCN, and to let folks know that there are those of us who are interested in patients and really looking for cures in these rare diseases. And I think that social media such as yourselves, and really all the internet media out there are actually really good sources. People have to be aware that there are pitfalls and there are misinformation out there. But in general, I think it's important to know that, yes, there's a lot of information and a lot of activity going on for patients with rare diseases such as BPDCN.